I'm going to be talking about lipodystrophy. This is a quote that I really love, which a previous dean of Harvard Medical School used to greet the medical students with to encourage them to continue lifelong learning. And I hope to persuade you through the talk that with lipodystrophy, we really have got half of lipodystrophy badly wrong. And we've done many bad things to our patients. We've told them wrong information. We've done inappropriate regimen switches. And I hope to persuade you that that is indeed the case as I go through my talk. All of you who treat patients would have seen lipodystrophy. This is fat accumulation. Typically occurs in the belly, buffalo hump, breast enlargement. Both of these patients were both my patients I looked after for a long time. They both also developed type 2 diabetes as a consequence of this visceral fat accumulation. And then, of course, there's fat loss. This patient was on therapy in the bad old days when we used D4T and DDI together. He'd been on that regimen for about 7 years, mostly self-funded. He wasn't too distressed by this appearance, but I think you'll agree that cosmetically it's pretty awful. And many people would be distressed by it, but this particular man was just happy to be alive and didn't really care too much how he looked. But clearly for most patients, this is a big issue. So fat distribution, it becomes progressively more common, and I'll show you some data about how common it does become with duration on ART. Anyone who's treated any group of patients for long enough will have seen it. You can get fat loss or fat gain separately or together. And it doesn't actually make sense to use the term lipodystrophy. When somebody says, my patient's got lipodystrophy, what should I do? That doesn't mean much to me. I need to know what is happening. Is the fat loss? Is it lipoatrophy? Or is it fat gain? What is going on in your particular patient? Or is it both? And in putting together this talk, I've tried to focus on randomized trials. And I've also tried to focus on randomized trials that have used objective measures of fat. There are these wonderful subjective questionnaires, which those of you who've done clinical trials might have come across, where they say, are your legs somewhat fatter than they were? Or is it more noticeable that your buttocks are thinner? These kind of questions which are very subjective. We do know what lipoatrophy looks like when it's severe, but it's very difficult to quantify it. And unfortunately, a lot of research is done using those subjective criteria, and it doesn't really make a lot of sense. So I've tried to focus on objective imaging wherever possible. To build my case. So fat loss, we think about fat loss in the limbs and the face and what they call in my clinic the vanishing bum syndrome. But in fact, it's subcutaneous fat pretty much everywhere. When you do MRI scans or CT scans, you see that it's not just confined to those areas, it's just that those areas is where patients most notice it. And fat accumulation, I've spoken about that buffalo hump, the visceral fat and breast enlargement. But in fact, it can involve subcutaneous tissue as well. So the three questions that I'm going to try and answer for both types of lipodystrophy are, what's the pathogenesis of fat loss and fat gain? Are they linked to specific ARVs? And very importantly, does switching help? Because if we switch patients and there's no point in doing so, a lot of harm can be done, and this is where I think we have actually caused a lot of harm in the past. So let's kick off with fat loss. Fat loss's pathogenesis is very well understood. These biopsy studies that are referenced below show typical features on histology. You can see the number of mitochondria are reduced. There is infiltration of adipose tissue with macrophages, and gene expressions show that pro-inflammatory cytokines are present in the fat tissue, and the consequence of that is that there's increased apoptosis of adipocytes. So a lot is known about the basic histology and what's happening at an inflammatory and a molecular level. And the basis for much of this is believed to be NRTIs that are most toxic to mitochondria, especially D4T, DDI, and AZT. There are a number of studies which have also pointed to genetic factors which increase or decrease the risk of lipoatrophy. So the pathogenesis is really pretty well sorted out for fat loss. Let's look at some randomized controlled trials. Now here are three. The graph shows fat in the arms. The grey bar is a back over 3-TC efavirenz. The black bar is D4T 3-TC efavirenz. You can see D4T patients losing weight, a back over patients gaining weight, and these two other studies of tenofovir versus either D4T or AZT showing increases in limb fat that are much greater in the tenofovir arm than in the D4T arm. The study was a randomized trial, but in this particular study they didn't randomize the NRTIs. They allowed the clinicians to choose, but it's one of the biggest studies that have looked at fat redistribution in an objective way. And you can see at 96 weeks, patients on stavudine, 42% of them have got lipoatrophy, which they defined as losing more than 20% of limb fat from baseline, versus 27% on AZT and 9% on tenofovir. That doesn't necessarily mean that tenofovir is causing weight loss. It's just that in a population, some people are going to be losing subcutaneous fat in the limbs and some are going to be gaining. So it's not clear what the baseline would be without antiretroviral therapy. But it is clear that D4T is worse than AZT, and both are considerably more associated than tenofovir is. But it's not just the NRTIs. This is one of the ACTG studies where there were 3 arms. It was lopinavir versus efavirenz, both with 2 nukes, and the clinician could choose the nukes, or lopinavir plus efavirenz together without any nukes at all, a nucleoside sparing regimen. And what you can see here is that patients on efavirenz have more fat loss than people on a PI, and people on a PI plus efavirenz have the least fat loss. So often we think the PIs cause more lipodystrophy, but actually if you look at fat loss, efavirenz or the NNRTIs, because the same pattern is also seen with nevirapine, are associated with more fat loss than the PIs are. Switching studies, if you switch away from D4T or AZT to abacavir or tenofovir, you do see weight gain, but when I say you do see it on DEXA scan. 400 grams of fat gain after 1 year is not something that the patient's going to see or that you are going to see. And I can't find longer term studies than 48 weeks to see whether this trajectory continues, but it would need to continue for many years before patients who've lost often 8 kilograms of limb fat would feel normal again. My gut feel when people have got severe lipoatrophy, from my experience, you only see partial recovery, if at all. You seldom see full recovery. But at least it does tell us what the pathogenesis is. It's the toxic NRTIs, take them out of the picture, and the situation does improve. So there is a rationale for a regimen switch. So just to sum up, we understand the pathogenesis very well. We know which ARVs cause it. PIs are less associated. Why is that? It might be that PIs are anti-apoptotic. We know that PIs do have some properties to reduce apoptosis. And it may be that when somebody's on NRTIs, which is causing the fat loss, if they're also on a PI, that might slightly counterbalance it by reducing the amount of apoptosis, whereas NNRTIs don't do that. That's an hypothesis. And finally, a switch in regimen to a non-toxic drug is a rational thing to do, although if you do it too late, if you wait till there's severe lipoatrophy, you're not going to see very much benefit. So let's move on to fat accumulation. This is the half I believe we've got wrong. Protease inhibitors are the fall guys for this. This used to be called protease paunch or Crick's belly, Crixivan being the trade name for indinavir, which was one of the first good PIs around. It's now toxic junk you wouldn't give to your dog, but in those days it was the greatest stuff ever. And people spoke about Crick's belly. This was a real phenomenon. It was clearly linked to the protease inhibitors. So let's examine the evidence around fat accumulation. One of the first studies to look at this was a strategy study. It was quite a strange study because people were randomized to a strategy, but the drugs that they got was up to the individual clinic. And their strategies were PI first or NNRTI first, both of them together with 2 nukes, versus PI plus a non-nuke together, a nucleoside sparing regimen. So these three strategies, people were randomized, and then the clinician could choose what was going on at the day, which is in the late 90s, early 2000s. So most of the PIs were not boosted with ritonavir, and about 50% of the patients were using AZT and a little bit fewer using D4T. But the sub-study, which is published in this journal, they looked specifically at fat with these three very strategies. Now, if PIs are the main cause of fat gain with a Crick's belly, you should clearly see something here. So what did they show? Well, this is limb fat. You can see limb fat increasing, and then as the mitochondrial toxicity starts to bite, it drops off. Trunk fat, which does include visceral, this is waist visceral area, increasing over time. No difference by strategy. So the amount of fat accumulation in the BUP is the same with a non-nuke, it's the same with the PI, and it's the same with the PI plus a non-nuke without any RT inhibitors. So this is the first big study which really shakes the foundations of the PIs are the problem. The next study up is efavirenz versus lopinavir ritonavir. It's a bit of an unusual study in that if people in the lopinavir arm of this study got undetectable, they dropped the AZT and 3-TC, so it was a kind of induction maintenance. But if you look at the fat gain here, trunk fat, efavirenz, trunk fat, lopinavir ritonavir, no difference at all. The only difference really is limb fat on the non-nuke dropping, whereas on the PI it's increasing. But remember, in this study, the PI arm dropped the NRTIs after a while. But in terms of fat accumulation, again in this study, PI versus NNRTI, absolutely no difference in fat gain. Another study, bigger study this time. Trunk fat increased from 8.2 kilograms to 10.4 at week 96. No difference. PI versus non-nuke versus PI plus non-nuke. So something strange is happening. You're seeing it with any old antiretroviral regimen you can concoct is causing fat gain to exactly the same extent. What about the new kids on the block? Raltegravir has just been launched. Metabolically, it's got to be the cleanest antiretroviral we've had in a long, long time. Doesn't affect lipids, doesn't affect glucose metabolism. Atazanavir, of the PIs that we have, causes maybe the least dyslipidemia, and people are really keen on atazanavir for that reason, long-term benefit. What do these drugs do for fat accumulation? Because surely the metabolic side is causing the fat, and surely there must be a link. So let's look at the data. First up, raltegravir versus efavirenz in naive patients. Fat gain at 48 and 96 weeks, absolutely no difference. So here is another completely novel class causing exactly the same amount of fat gain. No hint that this drug is going to be the solver of our problems. We're going to do away with fat gain by raltegravir. Let's look at atazanavir. This is unboosted atazanavir versus efavirenz. The white bars efavirenz, the grey bars, the white bars atazanavir, the grey bars efavirenz. The first one is looking at visceral adipose tissue, then subcutaneous adipose tissue, and then total adipose tissue. There were no significant differences. The study is a bit small, maybe a trend again showing that the non-nukes cause a little bit more fat loss than the PIs. Perhaps the PIs are protecting against apoptosis, as I suggested earlier. Bigger study, 4-arm study, where they randomized to atazanavir boosted or efavirenz, and they also randomized to Truvada versus Kyvexa. And the NRTIs, there was no difference in fat changes at all. The only differences seen were atazanavir versus efavirenz, where the fat gain was a little bit worse with atazanavir, not better. There was no difference in visceral fat. So once again, although you might say it's a little bit worse with atazanavir here, I think you're looking at subcutaneous is the main issue here again. Visceral fat, no difference. What about unboosted atazanavir? Surely it's ritonavir that's causing the problem. We know ritonavir is associated with a lot more dyslipidemia, and when you give unboosted atazanavir, you get less cholesterol problems. Maybe that solves the problem. Well, the net effect of this study was that actually you get a little bit more lipodystrophy with unboosted than with boosted. And the difference again comes in limb fat loss. So this is limb fat at week 96, more marked with the unboosted than with the boosted. But in terms of fat gain, visceral fat at 48 weeks, 96 weeks, no difference whatsoever. There was a significant difference. The ritonavir seems to be protecting a little bit against the fat loss. Once again, PI effect kicking in. But in terms of fat gain, unboosted or boosted, the same, no difference. What about switching studies? All of the studies I've shown you to date have been patients who are starting therapy, and you follow them over time looking objectively at fat redistribution over 1 or 2 years. What about switching studies? Well, if you look at the literature of switching studies, it's actually pathetic. This is one of the biggest studies ever done, and shattering surprise, because it was a negative study, it's not been published. It was first shown at a conference in 2008, and by scratching around for a long time on the internet, I find the final study report on the company website and at clinicaltrials.gov. So they randomized patients who were undetectable on a boosted PI, who had what was thought to be Crick's belly from their protease inhibitor. They switched to atazanavir in the belief that this drug might improve the situation, and there was absolutely no change in fat gain at week 48 or 96. So people who've got established lipodystrophy, if you switch them to atazanavir, you find no difference. Now, if you go into literature, you'll find a lot of small studies which should really not be published, in my view. There are 10 patients here and 15 patients there that look good, but really, I don't believe that they deserve to be in press, whereas this study should be published, and it's not. Those of you who know someone in BMS, start shouting. And raltegravir. This study was shown at CROI recently, switching people from a PI to raltegravir. It's a small study, unfortunately, but they looked at fat by DEXA scan after 48 weeks, and there was no difference yet again. Is it just my view? No, these are 2 recent review articles on the matter of fat gain and ARVs. This is what they had to say. We do not recommend it. And the second one, it cannot be advocated because there is no good evidence. And that's what we've been doing. People are saying, what should I do? On Alluvia, they're doing this. Why don't you try a bit of that? And now, can't wait till raltegravir comes available. Let's try for a section 21 to get it because that's going to help. But actually, it doesn't. Regimen switches don't work. So why do we do them? We do them because we like to do stuff. We're doctors. We like to do things. We don't like to say, we can't do stuff. That's not in our nature. I think what's happening, if you step back and say every single antiretroviral regimen that you can dream up causes fat gain. Maybe what's going on here is fat gain is a consequence not of any antiretroviral like fat loss is, but it's a consequence of treating the infection. The infection is associated with immune activation. I've chosen here 2 cytokines which are associated with weight loss, especially TNF-alpha, which used to be known as cachectin. This is the cytokine par excellence that causes weight loss. Here's in HIV-negative people what the cytokine concentrations were of TNF. CD4 count above 200, it's higher. Less than 200, it's even higher. After 2 months of ART and 4 months of ART, it's dropping back to the levels you see in HIV uninfected people. And the same picture is seen with interleukin-6, which is another pro-inflammatory cytokine. So what seems to be happening is you treat HIV and they gain fat. It's not a drug side effect. Yes, the drugs do have metabolic side effects, which are well known. I'm not going to go into them, and those are problematic. But fat gain is not one of the metabolic side effects. The metabolic side effects are separate. Those are specifically drug-related. So my take on it is that all ART regimens cause fat gain. No regimen switch effective. Yes, you can point to the 10 patients here and the 15 patients here. Some of them in good journals. Lousy studies. Not randomized at all. And I put to you that this hypothesis that fat accumulation is a consequence of treating HIV, not a drug side effect. Now, to make this point clear, the final nail in the coffin, you have to go to population controls. And I'm going to spend some time now doing just that to see what is happening with fat gain compared with HIV uninfected people. And the biggest study here is something called the FRAM study. This took patients who were on antiretroviral therapy for a long period of time. They did an MRI to measure their total body fat, and they repeated the MRI measure 5 years later. They compared them with controls who were being followed up for one of these cardiac cohorts to see what long-term risk factors there are for cardiac disease. This cohort had been going since the 1980s. They were reasonably well matched, the controls. Ethnicity was reasonable, but in the HIV-infected cohort, most of the men were MSMs, men having sex with men, whereas in the cardia study it was unknown, but it would be unlikely that most randomly sampled men in America would be MSMs. So there is that one issue that you just need to bear in mind when I show you this data, that the male cohorts may be a little bit different. There are many differences in lifestyles of MSMs that might account for fat differences. So I'm going to take you through the studies now to try and look at the question is fat gain in people on antiretroviral therapies, if it's such a big deal, and we think it is a big deal, we've seen it, Dave's seen it, it must be real. If it is real, it has to be worse than the general population. Busy slide. The light grey bar is the first MRI scan, and the dark grey bar, the black bar, is 5 years later. So these two bars are 5 years apart, HIV positive and control in each little box. And the difference in women is that there is less subcutaneous fat. This is the effect of the NRTIs causing fat loss. In the legs and in the arms, they have significantly less fat. However, in the lower trunk and the upper trunk and the visceral fat, there is no difference in fat. Not more fat in people on ARVs, the same as controls. The only difference in HIV-infected patients versus controls, HIV-infected women versus controls, is they have less fat in their limbs as a consequence of the NRTIs. Fat gain, no difference. Men, the situation in men, overall, pretty much wherever you look, men on antiretroviral therapy have less fat than control men. They have less fat not only in the limbs, but also in the lower trunk, the upper trunk, and less visceral fat. Not more, less. So if the ARVs are causing these enormous paunches and these terrible buffalo humps, by the way, this would be the area that the buffalo hump would pick up on the MRI scan, less than the controls. So if our antiretrovirals are doing these terrible things, these terrible disfiguring fat redistributions, where is it? It's certainly not there in the woman. In the men, you could argue that maybe MSM go to the gym more often, maybe recreational drug use is more common, and some recreational drugs cause weight loss. Yeah. There may be factors. So let's try and have a look at an MSM cohort, which I'll take you through in a few slides' time. Before I do that, I wanted to go through this fat loss, fat gain thing. This is slightly more complex. Here they're looking at the legs only, and they broke the patients up into quartiles, the ones with the highest 25% and the lowest 25%. Grey bars, HIV positive, the white bars are controls. And what this shows is that people who start off with lower fat in their legs end up after 5 years with even less fat, whereas the controls stayed pretty much the same. So the net effect is that people who have lost weight will continue to lose even more weight, and that's an HIV antiretroviral effect. Visceral fat, everybody gains. The middle age spread is a real phenomenon. I keep telling my children, who started calling me Bupo Man, till I got a bicycle, which is now gathering cobwebs, I hate to tell you. But no matter which quartile you were in, the fattest quartile or the thinnest quartile, everybody, controls and HIV positives, gained the same amount of visceral fat, not more produced by these noxious antiretrovirals, the same. So the FRAM 1 and 2 studies, subcutaneous fat loss is more common, and that's a real phenomenon. Visceral fat is not different. Accumulation over time is no difference. It's the amount of fat that you see is similar in women, amount of fat gain, but it's actually less in men, but this might relate to this MSM difference in the two cohorts. So let me take you to the MAX cohort study, which is a long-standing cohort of MSMs in America. Unfortunately, they haven't done a proper population-based DEXA scan study. They did a cherry-picking study, which doesn't mean anything. So, but this is their population data, and it's a simple anthropometric measure, which is waist circumference. The top line is waist circumference in men having sex with men over 5 years, increasing the middle age spread. The bottom line is MSMs who are on antiretroviral therapy. They are catching them up. So even within the MSM populations, men have less fat gain when they're on antiretroviral therapy, not more. To me, this is the final nail in the coffin. I think what's happening is the loss of subcutaneous fat is real, and it makes people look a bit strange. If you've got the book that your lifestyle deserves, those beers and the middle-age spread and the lack of exercise that I'm guilty of, if you get that and it's coupled with you've lost subcutaneous fat everywhere, not just in your arms, everywhere, you look a bit funny. And that's what's made us call this a lipodystrophy syndrome. But it's not really. What we're seeing is a subcutaneous fat loss, which is a real drug-related side effect, and that makes people look strange. It does, of course, have consequences. This study used an unusual endpoint. They used a CT scan to look for coronary artery calcification as a marker for coronary artery disease, and they showed that both fat loss and fat gain, but especially fat gain, were associated with an increased risk of having calcium in your coronary arteries. And at the CROI, the FRAM study, the same one that I showed you earlier, showed that lipoatrophy was not associated with increased mortality, but visceral fat accumulation was. This did increase mortality. So it is not something to be ignored. It is a marker for vascular disease, and you need to be aware of it. But it's also a marker for mortality in people who are HIV uninfected. So gaining visceral fat is not good for you. It is an independent risk factor for coronary artery disease, well established, possibly even more so in HIV because of the metabolic consequences of the drug, not because the drugs are putting more visceral fat in the stomach in the first place. I'm going to close with a few remarks on breast changes. There's not much data here, but this was sent to me via Steve Andrews from Francois Fenter. Apparently, Sowetan clinics had terrible adherence shortly after this. This unfortunate HIV-infected patient was on antiretroviral therapy and developed quite marked and disfiguring gynecomastia. There's very little on this, and it's not a very common side effect, but we get quite a lot of reports on our national HIV hotline that we run in our Medicine Information Center of this. And the drug that's most implicated here is efavirenz and possibly DDI. There's also testosterone issues going on, so if you see it, you need to measure the testosterone. But efavirenz is the drug that seems to maybe do something to the breast. And very recently, this other paper has popped up to suggest that when you take breast cancer cells in the test tube that are expressing the estrogen receptor, and you sprinkle the amount of efavirenz that you would expect to get in a patient, that the cells grow faster. So it may be that efavirenz is interacting with the estrogen receptor, and if you have a patient with isolated breast enlargement, that stopping efavirenz or switching away from efavirenz might be a good idea, but there is no data behind that. This is all anecdotal at the moment. So just to wrap up, Fat loss, very well understood. We know that switching is a good idea and it works, but you need to switch early. Fat gain, I hope I've convinced you, is not linked to any antiretroviral. Every single combination antiretroviral regimen you might ever want to use causes it. And I don't think, and this is the big nail in the coffin for me, there's no increased fat accumulation in HIV-infected people when you compare them with controls and you measure it objectively. They look a bit weird because the subcut fat is lost. There is no rationale for switching ARVs to improve fat gain. More studies need to be done and should be done. The literature is really awful on this, but what you can find from the literature is not encouraging. And finally, when you see people who have fat gain, as you would in general practice in somebody who's HIV uninfected, check their blood pressure, see if they're diabetic, look at their lipids, tell them to stop smoking, and buy a bicycle, which they can also grow cobwebs on. Thank you very much.